Good afternoon and welcome to our special Medicare webinar. We're glad to have you join us today. My name is Brent Hunsberger. I put together the Oregonian OregonLive's annual Medicare Open Enrollment Guide. The guide appeared on October 11th and 24th in the newspaper, and it will appear again this Sunday. I'm also a financial planner and the paper's former personal finance columnist. For those of you new to Medicare or those re-enrolling, we know that this is a very important and frankly personal decision for yourself or for your loved ones. Over the next hour, we will be hearing from two Medicare experts. We have Lisa Lettenmaier, owner and insurance broker with HealthSource Northwest in Tigard. We also have Hedy Towan, a volunteer at Clackamas County Senior Health Insurance Benefits Assistance Program, also known as SHIBA. Thank you again to everyone for joining us. So here's what you can expect today. Our panelists first will cover the basics of Medicare. Then we'll talk about the differences between Medicare Advantage and Medigap. Finally, we'll cover what to consider when choosing a prescription drug plan. We will be answering your questions along the way, but listen closely because you might hear the answer as we go. We'll bring both of our panelists back at the end for any questions you might have. So submit any questions you have via our Q&A box. Just click Q&A at the bottom of your screen. To ask a question, type your question into the Q&A box and then click send. If the question is too specific to one person's circumstances, I might have to skip it. So try to keep it as broad and general as possible. Also, this program is being recorded. Even better, the recording will be emailed to you within the week. So you will have an opportunity to rewatch and reabsorb all this important information covered today. So you don't need to take notes furiously. Now, last month, the Oregonian published a special Medicare guide, which is also available on OregonLive.com. As I said, we'll be publishing it again Sunday. The guide compares the benefits and costs of the 8 largest Medicare Advantage plan providers in the Portland area. It also has information on prescription drug plans and Medigap plans. You also find resources if you need help navigating this choice. Again, you'll find this all online at OregonLive.com. All right, let's start our series of discussions with the basics of Medicare. This will be good for those who may be first-timers and a nice refresher for those re-enrolling. Joining me now is Lisa Lettenmaier, an owner and principal with HealthSource Northwest in Tigard. Lisa spent more than 15 years in the accounting field before moving into insurance, so she's got a keen eye for details. Since 2004, she's owned HealthSource Northwest, an independent insurance agency that helps consumers select, enroll, and review Medicare insurance products. Lisa and her husband, Kim Lettenmaier, run the agency together, and in her spare time, she likes going to Disney, on Disney trips, gardening, and volunteering for the 4-H horse program. Thank you for joining us today, Lisa.
Thank you. Thank you for having me, and for everybody who's online. I am going to shut off my video just while I'm talking because I find that it's distracting for me. But we'll be going through, as Brent said, Medicare Basics, which is Medicare Part A and Part B.
Yeah, so you can start with just describing what makes a person Medicare eligible.
Yeah. So Medicare eligibility, actually, for most of us, that's achieved when we turn 65. So the month that we turn 65, our Medicare eligibility is actually going to be the first day of our birthday month. So for me, I'm going to use as an example, my birthday is June 3rd. So my eligibility will end up being June 1st. Now, if I had been born on June 1st, my actual eligibility date would be May 1st. That's the only time it will differ. Other than that, if somebody is granted Social Security disability benefits, once they've been under disability benefits for 24 months, then they would become Medicare eligible. So that can happen, of course, under age 65. And if somebody is diagnosed with end-stage renal disease or Lou Gehrig's disease, ALS, then they're actually granted Medicare immediately. So that's the difference there. We'll move on to our next slide. So what I'm going to do today is I'm going to break down original Medicare. So this is the portions that we all pay our taxes into to be eligible at age 65 or sooner, of course, through disability. And I find that it's really important that we have a basic understanding of what the government's already giving us before we go out and shop for something else, so that we understand what it is that we're trying to protect ourselves against and how we need to maybe potentially change this. And there's going to be two different ways that you can insure above and beyond Medicare A and B, which Hedy and I will be going over in our next segment. So one thing I always like to clarify right here is that regardless of the way that you want to insure yourself, whether it's with a Medicare supplement or a Medicare Advantage plan, you do have to start with your foundation, which again is going to be Medicare Part A and Part B. So we're going to go through Part A first. Eligibility for Part A and B is actually based upon your working history. So as long as you can achieve 40 credits of working history in your lifetime, you're going to receive Part A as a zero premium at age 65. If you've not achieved those credits, if you're at kind of at a partial rate, you'll see here on the screen, for example, if you have between 30 to 39 credits, it's going to be $259 per month this year. And if you have less than 30 credits, it's going to cost you $471. Now, most people will achieve this easily enough. The last time I looked, your gross income per year needs to be somewhere in the area of 5,000 to earn 4 credits. That's the max earned per year. So most of us will hit Medicare eligibility within 10 to 15 years of our working history. If we don't qualify under our own working history, if we have a stay-at-home parent, then we can actually achieve Medicare eligibility through a spouse. So that is the other option. Through their working history. Now, Medicare Part B, that's a little bit different. When we get to Medicare Part B, the basic premium that everybody pays this year, the standard rate, is the $148.50. That's the base rate. That is for 2021. We have not yet seen the government release the rate for 2022. Now, there are many people that may pay a higher Part B premium, and that is based off of a program that the government came up with called the high income earner or the income related monthly adjustment amount. So if Social Security deems you as a high income earner, then you will face a higher rate of Part B premium, which will also potentially affect how much you pay to be enrolled in a Medicare drug program. This dollar amount, when they're looking to see if you qualify for a high income earner, they're actually going to look back on your tax return 2 years. So for all of my clients that were coming in 2021, Social Security was using their 2019 tax return. And even though you might be enrolling before your spouse, they are looking at that joint tax return. So again, the program is called IRMA. That acronym is IRMAA, and it stands for Income Related Monthly Adjustment Amount. But most people will end up paying the base rate. Next screen, please. So Medicare Part A. Now, when you get your card, you're going to notice that it says Part A hospital and Part B medical. And those are, decent enough terms, but I actually like to refer to Part A as inpatient type care and Part B as outpatient type care. I just think it's easier to kind of think about what's going to go into each bucket. So Medicare Part A, there's actually only 5 types of medical services that are covered under Medicare Part A. The first one and the most notable is the inpatient hospital stay or that hospital admission. And what the government has designed here is they ultimately will be paying or covering the majority of these costs, but they leave behind portions for you to pay. And we refer to these portions as gaps in coverage. So the first gap that we're going to come upon is what's known as the Part A deductible. So if you were admitted to the hospital, and again, as I explained Part A and Part B, this is before we do any other insurance planning. So if you were admitted to the hospital, whether your stay was 1 or all the way through 60 days, your Part A deductible this year would be $1,484. And it wouldn't matter if you were there 1 day or 5 days or all 60, it is the same dollar amount. Now that deductible is not an annual deductible, which most of us are accustomed to with our either individual or group health insurance plan. That is a per admission deductible. So it can affect you more than once in a year. We don't see it too often, but if you were still in the hospital on day 61, there would be additional costs. Currently, anything from day 61 to day 90 is going to run $371 a day. And if you are still there on day 91, it will double to $742 a day. So these again are going to be referred to through our presentation as gaps in coverage. And this is ultimately what we're trying to solve for later on with potentially insurance plans. The next benefit we're going to discuss is the inpatient skilled nursing rehab stay. So this is very specific. First of all, Medicare as a program was not designed, nor does it cover any type of convalescent or custodial care. So this particular benefit right here is specific to you entering a rehab facility after a hospital admission. And original Medicare's rules are very specific on this. If you were admitted to the hospital, your stay would need to be 3 days or longer before you qualified for this skilled nursing rehab stay. This is for a 24-hour care facility, and this is meant for somebody who's obviously stabilized. They don't need to be in the hospital anymore, but they can't go straight home. There's too much that needs to be done throughout the day to take care of them, so they're going to go to this rehab facility. Now, cost-wise, if you're there for days 1 through 20, the government covers that in full on your behalf. However, just like the extended hospital stay, if you're still there on day 21 through day 100, which is the maximum allowed time, you will pay a per day rate. And currently that is the $185.50 per day. All these dollar amounts that I'm showing you today, these are going to most likely change and trend up as we get notification from the government for 2022. Next slide, please. All right, the last 3 benefits under Medicare Part A, the first one is blood transfusions. So in the event you need a blood transfusion in a hospital setting, the government will require that you pay the costs associated with the first 3 pints. Now, obviously, you're not going to pay for the blood, it was donated, but you're going to pay for the testing and prepping and the transfusing that takes place. So those costs associated with the first 3 pints are yours. If you ended up needing 4 or more in a calendar year, that's when the government would take over and pay the rest. The last 2 benefits you're going to see here, there is no gap in coverage. There's not going to be anything for you to pay, but both of these services are very limited. So I always like to just kind of give you a brief idea of what to expect. Home healthcare services are specifically deemed for somebody who is considered homebound. So that might be a physical limitation. It might be just your overall health prevents you from leaving your home safely to receive care. Your doctor would need to prescribe home healthcare services, and they need to see you in person to be able to prescribe that initially. From what I've heard talking to professionals, normally they'll set this up for an initially 60 days. They can re-up it if necessary. It really isn't meant to be a long-term ongoing benefit. This is very short-term intermittent care in your home when it's necessary and you're considered homebound. The home health care technicians will be out to your home anywhere from 2 to 4 times a week, typically anywhere from an hour to 2 hours at most. So again, very limited. If you were needing additional services around the clock, you're going to be relying on friends and family, or you may have to hire somebody into your home at your own cost. So again, what the government's going to give you doesn't cost you anything for those services, but they're very limited. The last one here on the screen is hospice. Obviously the most difficult to talk about. Most of us have had some experience watching friends and family transition through hospice. This is where we are deemed terminally ill with less than 6 months to live. So once you're placed on hospice, there will be no more further treatment. It's all about comfort and palliative care. You have a choice to make. Once you're on hospice, you can choose to receive hospice services in your home, or you might need to be in a 24-hour care facility based upon your needs. If you are at home, which is where most people want to be, what'll happen is the hospice team will come in and they'll make a needs assessment. Usually the first thing they're looking at is bringing in any additional medical equipment that's needed. So they'll coordinate that, bring it in, set it up. They will take over the management of all medications, and you won't be paying for the hospice services themselves as they come in. You may pay no more than a $5 copay for the medications. But the hospice team is going to take over. They're going to manage everything. And from the point that they set everything up, you're going to see them probably twice a week. They'll come in, replenish supplies, answer any questions. They can perform a bath aid. But that's going to be it. You're only going to see them twice a week. Now, they are available by phone 24/7 if you have concerns or questions, and they can come out to the home if there's an urgent situation. But generally speaking, it's twice a week. So any other services that you bring into your home, you'll pay for. Or on the other hand, if you're in a care facility, even if they refer to it as a hospice facility, The room and board for that facility while you're there is going to be your responsibility. The only time that would differ is if you were there under what we call respite care. So maybe your family's been taking care of you at home and they need a break. So you would go into a care facility for several days to give your family a break. And while you're there under respite care, that would be covered by Medicare, but it's a very limited benefit. And I'm not even sure of the exact details on how that works out. So that is Medicare Part A. Next screen. All right, so Medicare Part B, as I mentioned earlier, the government refers to this as Part B medical. And I like to use the term outpatient, just because I feel that what happens under the umbrella of Medicare Part B is really outpatient services and procedures. So I'm going to go through this quick list right here and just kind of touch on a few things that I want you to know about, and then we'll talk about the cost. So right now I'm just talking about what's covered, and then I will discuss the gaps in coverage a little bit later. So first of all is your doctor visits. Of course, that would mean being able to see your primary care or a specialist. There is also coverage for outpatient mental health and physical therapy, occupational therapy. There is a very limited amount of chiropractic and acupuncture, but there is no naturopathic services. Moving on from that, you've got your outpatient surgeries and services. So this is actually quite a large category these days, because what they're able to do as far as outpatient surgeries is more significant than we've seen in the past. So in the past, it may just be the cataract surgery or a simple shoulder repair or hernia. Now we're seeing doctors perform partial and sometimes full joint replacements on an outpatient basis. They can do some heart procedures. So some of these surgeries are pretty significant, both in cost and what they're doing. Services could be things like dialysis, radiation treatment, chemotherapy. In addition, what's not listed here would be any outpatient diagnostics. Actually, I guess it's further down the list here. So anytime that you're going into a medical facility, whether it's an ambulatory center or hospital, and they're doing a surgical procedure or service, and you're not being admitted to the hospital, it should fall under Medicare Part B. Of course, we've also got emergency and urgent care services. So if you needed to go to the emergency room because you cut your hand or broke a bone, or needed urgent care services because maybe you thought you woke up with strep throat or you have a UTI and you can't wait the 3 or 4 weeks to get in to see your primary care doctor, those will fall under the coverage of Medicare Part B. As I mentioned briefly earlier, of course, outpatient diagnostics, so any type of labs, x-rays, major imaging, other tests such as an EKG or a stress test, all of those done on an outpatient basis fall under Part B. And then we've got durable medical equipment. So wheelchairs, walkers, medical beds, oxygen tanks. This could also be for diabetic supplies like the monitoring devices and test strips, or if you needed to use a CPAP machine, it would be for the machine itself, along with the replacement hoses and masks. And then if you need an emergency transport, so Medicare will cover an emergency transport to a hospital for your care, whether that's ground or air if necessary. It needs to be emergency based and it needs to be a transport. If for some reason the ambulance shows up at your home and deems that they don't need to take you in, that you're stabilized, you may actually receive a bill for that ambulance showing up at your home that would not be covered by Medicare because there was no transport involved. The last benefit we're going to discuss is Medicare Part B drugs. Now, later on at the last segment of our presentation today, Hedy is going to talk about Medicare Part D, D as in David, which is prescription drugs. But Medicare Part B drugs are different. These are typically medications that are going to be administered to you by a healthcare practitioner in a health setting. So examples could be certain injectables, infusion therapies. So most of the chemo drugs are considered Part B drugs. In addition, if you're using a medical device, such as a nebulizer machine or an insulin pump, the medications within those medical devices are also deemed Part B drugs, which means that the cost for those will fall under your medical plan. So I've gone over the majority of what you'll find in a Medicare Part B. There are some other services, but this is the bulk of it. Now let's talk about how much you have to pay. So we already know that there's going to be that monthly premium. Currently it's stuck at $148.50. We'll see where it goes next year. But in addition to that, there is a deductible for Medicare Part B. So for this year, for 2021, the government has set that deductible at $203. And the good news is it is an annual deductible. So very similar to a typical health plan, you only need to meet that deductible once per year. Now, after you've met your deductible, you and the federal government will share the remainder of these costs. All these things that I've been talking about will be split. The federal government will pay 80% and you will pay 20% of the cost. And unfortunately, very different from a typical health plan where you may have an annual out-of-pocket max, which is the dollar amount that lets you know in any calendar year, the worst that you're going to come out of pocket is whatever that annual out-of-pocket max dollar amount is. When we look at Medicare Part A and Part B, there is no cap to how much you're going to pay. So all those costs I was talking about, whether it's the Part A hospital deductible, the daily rate for the extended hospital care or skilled nursing, the Part B deductible, and most importantly, that 20% for all those Part B services, you're just going to pay your portion regardless of what's happening that year with no stopgap. So that's where people have the biggest exposure, is you've got these gaps in coverage with no way to know what that's going to be from year to year based upon your health history. In addition, as you've noticed, I did not discuss prescription drugs. That comes along in a separate program, as I mentioned earlier, Medicare Part D. So the big thing for people is to figure out, okay, so if this is where I'm starting, where else do I need to go from here? What are my insurance options to maybe protect myself and either put some caps in place or maybe fill in those gaps and then decide if I want prescription drug coverage. One more thing I'll say here before we move on and bring Hedy back on is that with original Medicare Part A and Part B, you are allowed to actually seek medical care at any doctor or a medical facility in the nation, as long as they agree to bill Medicare. So it's actually very easy to use access-wise. There's no referrals or prior authorizations. The key point is, do you need medical services? Are you sick or hurt? And then you can seek care at anybody billing Medicare.
Thanks, Lisa. I've got a couple of questions for you.
Okay.
Very good, very comprehensive. You described how the Part B deductible worked. What about the Part A deductible?
So that is a per admission deductible. So if you were admitted to the hospital, and let's say that happened in February and you were there for 3 weeks, and then here you're back out, you're home, and something happens and you're back in the hospital in July, you're going to pay that Part A deductible again. It is a deductible that is within the first 60 days. So if you were in the hospital and admitted for 2 weeks and came home and you were back there in a week, that should be the same deductible because it's within the first 60 days. But again, if it's outside of that, you're going to be paying that Part A deductible per admission.
Got it. And we also have a question from Lyle, who is turning 65 next year. He wanted to know how to transition from an Obamacare plan to Medicare. I presume he would just call Social Security 3 months before he turned 65. Is that right, Lisa?
Yeah, it's a good question. So if you, especially if you're on an individual health plan, you do need to move on to Medicare. Individual plans were not designed for Medicare beneficiaries, and you are considered eligible on your 65th birthday month. If you're receiving any kind of subsidies from the ACA, the Affordable Care Act, those subsidies are not applicable once you become Medicare eligible. So if you've been relying on those to help with the premium payments, that goes away the month you become Medicare eligible. So another reason to get off that plan and go on to Medicare. And yes, to your point, Brent, generally speaking, your enrollment in Medicare Part A and B can start as soon as 3 months out. So again, using myself as an example with a June birthday, I can start my Medicare enrollment in March 1st. So anytime I enroll in those first 3 months, my effective date will actually be June 1 in my example.
All right. Well, we've got other questions coming in. I'll be getting to most of them soon, and some of what we're talking about will also address those questions. So hold on. Thanks so much again, Lisa, for this insight, but keep the questions coming. Now, as you know, or as we all know, Medicare is not a one-size-fit-all program. So now I'd like to invite Hedy Towan to the stage as well, along with Lisa, and we're going to talk about kind of the differences between Medicare Advantage and Medigap plans. We've been focusing, or the coverage of the newspaper has been focusing on Medicare Advantage because it's open enrollment right now for those plans. But as Lisa noted, there is another option, and that's Medigap. Hedy, can you tell us a little more about Medigap and how it works? Oh, you're muted, Hedy.
Let's unmute.
There
Okay,
we go.
we can talk about Medigap here. And before I start going into all this material that is here on the slide, I just want to let you know that Medigaps, the way they came in before Medicare Advantage plans were there. And as you heard Lisa talk, there's a lot of gaps in coverage that come out of your pocket when if you only have Part A and Part B. And so these Medigaps came along. By the way, they're also called Medicare Supplement Plans. You may hear that term. So these came along and said, okay, we'll kind of help ensure some of those gaps that were going to come out of your pocket. And so when you go down on the left side of these charts, you're going to see this chart sometime whenever you're going in to look at Medigaps, you're going to run into a chart that looks like this. And the left side is going to show all of those expenses that might have come out of your pocket if all you had was the original Medicare A and B. And so that Part A hospital coinsurance and the Part B coinsurance and all of those things are designed by these different Medigap plans for coverage. So if you look at, as you go down the alphabet here, you'll see yeses and nos in the column. And that means, for instance, in the top row there, Part A hospital coinsurance, you can see that all of them there have a little yes, which means they're all going to cover that. But say you were looking for coverage for that hospital deductible, that $1,400 and something when you go into the hospital. So you'd go down the chart to Part A hospital deductible, and you see that, oh gosh, in the A column, there's a no. So if I wanted to make sure that I had that coverage, I wouldn't pick an A-type Medigap plan. I'd want to look at a B-type or C-type or D-type. And as you go along, the more yeses there are, of course, the more expensive these plans become. And I should mention here, when you're looking in a book at a Medigap plan listing and they show you a price, that price is for a non-smoking female. So if you're a smoking male, expect that you'll pay a little bit more than that when you actually enroll. Keep that in mind. And all the prices you see are in addition to that Part B premium that you're paying. So you're paying that Part B premium, that $148.50 this year, you're paying that to Medicare to have Medicare. Any price you pay for a Medigap plan is going to be in addition to that. Just like with the Medicare Advantage plans, if you see a premium in a book, it's going to be in addition to that Part B premium. Okay.
Hedy, let me ask you a question here. Well, first, sure. I'll clarify also these prices that you see on the screen are from 2016, so they're not current. This is kind of an old chart.
This is an old slide.
One question, can you explain the difference between the F and G plan? They look very similar here on this chart.
Yeah, I can. And they are very similar. And the F plans went away. People who were eligible for Medicare prior to 2020 could be eligible for a Part F plan even still. But anybody who's new to Medicare after that cannot get an F plan because they did go away. Partially, they were covering the Part B deductible, which is no longer being covered. In kind of replacing that and taking over in its stead is the Part G plans. And those are the most comprehensive coverage. So if you wanted just about everything covered, you don't want anything out of pocket, you'd pick a G plan. Now, obviously, they're going to be more expensive. But if you look down at the Part G plan, you'll see that it has a no, just like everybody does for the Part D deductible. That's something the gaps don't cover, and you will have to pay. Okay, hopefully that's clear as mud. So this can be daunting, but as long as you understand that left column is things that could come out of your pocket, pick a plan that covers the things you're concerned about.
Now, Hedy, do these plans cover dental, vision, or naturopath?
No, they do not, because original Medicare, Part A and Part B, don't cover that. It doesn't cover drugs because they only cover things that were approved for original Medicare. So you're not going to see naturopathy things and again, drugs. You're not going to see that in here. If you wanted to add that on to your coverage, you'd have to add on a drug plan.
Got it. And you'll talk about those drug plans in a little bit.
I sure will.
And one more thing to clarify really quick, I'll jump in here before we go to the next slide. when you're dealing with this type of coverage, remember that Medicare A and B is your primary, which means the federal government. So when you go to the doctor, when you go to the hospital, those bills that are generated are going to go to the federal government for payment. And then if you have a Medigap plan in place, a Medicare supplement plan in place, the government knows which carrier, which plan you're on, and they forward those bills on. It's called cross billing. So you're not involved in any of that. So as long as Medicare A or Medicare B paid the bill in the first place, and they forward it on to the Medigap company has to pay that bill. It's not like they're going to argue with you. If Medicare paid first, the Medigap pays second. That being said, if Medicare says, nope, we're not going to pay this bill, we don't feel that it was medically necessary, your Medigap plan will not pay the bill. And to Hedy's point again, just going to drive this home, if it's not a medically necessary covered expense under Medicare A or B, it's not going to be picked up by the Medigap plan. These plans, the reason that they're called Medigap is they were designed to fill the gaps left behind by Medicare A and B. So that's it.
Yeah, Lisa, why don't we hop off there to the next slide and you can talk a little bit about Medigap versus Medicare Advantage.
So as Hedy was just describing, Medigaps have been around longer. I actually don't know exactly how long, but they were designed to fill in these gaps because obviously people had concerns. The issue with them can be that, number one, the price points can be higher. And based upon your age, whether you're a smoker, non-smoker, male, female, those prices will also typically go up throughout the years. Number one, because of your age. Secondly, if the insurance carrier is having higher claims from one year to the next, you're going to expect those premiums to go up. On the plus side, there is no network, so you're not locked into any particular group of providers. You don't need a referral. So access is great. If you are somebody who travels a lot or you are somebody who snowbirds, that might be a better fit for you because you're not going to be concerned about, am I in or out of network? Do I need to get a permission or referral or prior authorization? So those things kind of dry up when you're using original Medicare with a Medigap plan. But again, if you're looking for some of those extras that you're seeing advertised quite a bit, especially right now on TV, whether it be routine vision or hearing or preventative dental or gym memberships, you're probably not going to see those on the Medigap side. And it's very rare that you'll see a Medigap company offer a gym membership or something, some kind of discounts. They're really just designed to fill in those gaps. So not necessarily, again, going to give you some of those extras. The difference is Medicare Advantage plans. So these are actually quite new, really, in the grand scheme of things. Since Medicare was designed back in 1965, the Medicare Advantage plans were officiated in 2003 in the Medicare Modernization Act. So in that act, what we had prior to this was known as Medicare Choice Plans or Medicare Health Choice Plans, and they were formalized into Medicare Part C. So if you've never heard that before, there is a Medicare Part C. That's the official title for Medicare Advantage plans. So they were formalized in that act along with the creation of Medicare Part D. That's when it all happened, was in 2003. So they're relatively new to the market. The idea here was if the government could still have that established course of coverage, what the government wants to have covered under Medicare Part A and Part B, but rather than the government processing and paying those bills, because they don't have an advice nurse line, they don't really focus on routine or preventative care services. Even back then, they didn't have preventative care services in Medicare. So could they work with a private insurance carrier to bring that management component in? So that's what's happened. So if you choose to enroll with a Medicare Advantage plan, whichever carrier you're going with is going to dictate the list of preferred providers and hospitals that you can access. And depending on the type of network you have, that might be a closed network like an HMO where you must stay inside your network and you would typically need a referral in an HMO, or they might be a PPO where you don't need a referral and you could be seen both in and out of network, but of course going out of network means a higher price point. But what we see, especially here in Portland Metro, this year alone, we have, I think, 43 plans. As we head into 2022, we've got 46 plans that include prescription drug coverage. So they're bundled together. And we've got several plans on the market that are a zero premium. And most people say to me, that doesn't make sense. How do I buy an insurance policy for a zero premium? So first of all, I remind them that you do still need to be enrolled in Medicare A and B, which means already you're still paying your Part B premiums. But the government is actually sending money to each of these Medicare Advantage carriers per enrollee on a monthly basis. And with those funds, the insurance carrier is required to cover all of the same medical services that would have been covered under original Medicare. And they're going to do this by, again, creating a network, and they're going to create a summary of benefits. So you guys may have seen this if you're already on a Medicare Advantage plan, where there's a list of copays and coinsurance per service that you're going to pay. But the government said, if you're going to charge these cost shares, these copays or coinsurance, throughout the year, there needs to be an annual out-of-pocket max. So it's actually part of the requirement now that if you enroll in a Medicare Advantage plan, they have to tell you right up front what the out-of-pocket max is for the year. Now that out-of-pocket max is specific to the healthcare cost. So any copay or coinsurance, and I'm going to clarify those really quick. A copay means it's a fixed dollar amount. If you look at the line item and it says doctor visit to the primary care, whatever is listed, that's the copay. Same thing with going to a specialist. Maybe that's a $30 or $40 copay. That means that's all you're going to pay for that particular service. Now, if it says coinsurance, that's where you're sharing the costs with the insurance carrier. And typically what you're going to see is an 80-20 split. So the carrier is going to pay 80% and you're going to pay 20%. But regardless, if you're on a Medicare Advantage plan throughout the year, those costs are going to go towards that out-of-pocket max. What will not go towards that is any copays for your prescriptions, if it includes prescription drug coverage, or any copays for other services that the carrier chose to add in. So that out-of-pocket max is focused on those medically necessary services. But we do see quite a few plans at a zero premium, a lot of plans even coming in at whether it be, $32, $35, $72. I mean, there's all kinds of prices going all the way up to $200. I always just tell people, quite frankly, you've got to focus on the provider network, the formulary for your prescription drug coverage. And once you've established that, a plan that fits your doctors and your current medications, and you can afford the monthly premium and the out-of-pocket max is something that you can handle, then if there happens to be a couple carriers that fit that, then we can start looking at those extra benefits, whether it be the gym membership or the routine vision or preventative dental or alternative care, but really focus in on getting your medical needs met first. You may need a referral. Again, with an HMO plan, in most cases, you're going to need a referral to go from the primary to the specialist. With a PPO plan, you wouldn't need that. We've already talked about those extras. And who's it for? So generally speaking, with my client base, if I've got somebody who doesn't do a lot of traveling, they certainly don't snowbird. They're here, 12 months out of the year, unless they go off for a couple of weeks. They might be more apt to go with a Medicare Advantage plan, or somebody who really hasn't had a lot of experience with major medical expenses. They've got one doctor, a couple maintenance meds, and they don't really want to spend a lot of money per month for a Medigap and a separate drug plan, and they just want to bundle it all together. So sometimes just the ease of having the medical and prescription combined with a few extra benefits, that in of itself is, may drive somebody's decision to go there. Who regulates these Medicare Advantage plans is actually not the state, it is the CMS, and CMS stands for the Center for Medicare and Medicaid Services. If you are having a problem with a Medicare Advantage plan, you're not going to want to call the state insurance division. They can't do anything. You can file a complaint or a grievance directly with the insurance carrier. They have to submit that to Medicare, or you can call Medicare directly. But they are not regulated by the state, just by the federal government. Whereas Medigap plans, different. Those are actually regulated by the state on how they're priced. As the carrier files new prices every year, those prices have to be approved by our state insurance division office. And then they are also kind of somewhat regulated at the federal level because they have to fit the guidelines that Hedy was showing you earlier on that chart. So that's kind of the main differences between these two options.
Yes, and Lisa, I think the reason Oregon is listed as under regulating Medicare Advantage is they do regulate the insurance agents or brokers who sell the plans.
Yes, we're regulated. At the state level, we have to have our insurance license to be able to do what we do. We renew that every 2 years. And then also at the CMS level, any agent who wants to work with Medicare beneficiaries go through annual training and testing on our Medicare knowledge. And then for any insurance carrier who sells a Medicare Advantage plan or Medicare drug plan, that insurance agent has to go through their training and testing every year. If we don't pass the testing at the end of the training, we're not allowed to continue to sell forward. But yes, we have to be regulated at the state and federal level.
All right, Hedy, there are some new benefits being offered by Medicare Advantage plans that go beyond medical care. Could you talk about those a little bit with the next slide?
Sure. This was kind of an exciting thing, started coming out last year, that these Medicare Advantage plans in particular, we're going to be able to provide some extra things that weren't given before. things like if you're at home and you're stuck there and you need services, you can get transportation for medical needs. You can get home delivered meals and foods and some support for maybe in putting in a ramp, people to come by and help you with various things that weren't allowed before. However, this is not typically offered to everybody. The Medicare Advantage plans can offer it, and you, when you go in there, you may find out, you hear all this great stuff on TV about all these new services. But if you're not chronically ill and stuck at home and certified by your doctor as being in such a situation and needing these things for your quality of life, for your health, then they're not going to be available to you. But the exciting thing is these are available, all kinds of wonderful things. And I found it very exciting because there are a lot of chronically ill, homebound people that didn't just need what was provided before, which was just maybe a nurse to come in and help with their meds. If they wanted any of these services, it would have to come out of their pocket. And now it's something that's considered a quality of life and good for their health care. And if they qualify, these are just wonderful new services that can be made available to them.
One question from the audience is how easy is it to switch between, if you sign up for Medicare Advantage, let's say when you're 65, to switch to Medigap plan later, or if you sign up for Medigap and switch to Medicare Advantage?
Okay, let's talk about that. With a Medigap plan, they don't have what we call an open enrollment period like we have for Medicare Advantage. They have what we call guaranteed issue periods. And what that is that when you first get Part B, for the next 6 months, you're in a guaranteed issue period. That means a Medigap plan has to accept you. They can't not accept you because you have complicated illnesses. You're not underwritten. And they can't charge you more than anybody else. They have to use their published costs. And so you're guaranteed to be able to get in there. On any other period other than your birthday, you can't get into them necessarily. They can say, no, we're not going to take you to, you're too expensive, or they can charge you more than the published rate, or they can just say, I'm sorry, I already covered, no, they won't accept you. But they can take you and charge you more if they want to, or they can just take you at the published rate if they're feeling generous. The other time that you can have a guaranteed issue period in Oregon and in California is once you have your birthday, for the 30 days after your birthday, you have another guaranteed issue period where you can look at gap plans. But the idea is they're not necessarily available anytime, but you can always ask and apply outside of those issue periods. The other thing to consider with them is when you're first brand new to Medicare, you've turned 65, you're eligible because of disability, you could pick a Medicare Advantage plan. Say you went that way. That was the very first thing you picked for coverage. And within the first year of having that Medicare Advantage plan, if you decided, no, that decision for me, I should have gotten a Medicare, you can, during that period, what we call a look back period, you can go back and get a Medigap at that point.
Okay, great.
And I'm gonna add to that just really, really quick.
Go ahead.
So when we talk about those open enrollment or guaranteed enrollment, again, they're typically specific. The two main times is turning 65. That's when you choose to go on Medicare. We have a lot of clients who will delay enrolling in Medicare Part B because they have employer coverage. So they're going to stay with the employer coverage. As long as your employer has 20 or more enrolled employees, you're not going to be penalized for that. You can delay Part B, not pay that premium, stay on the employer plan as the primary. And then sometime in the future, when you retire, you can then enroll in Medicare Part B. At that point, you would have this guaranteed issue option or open enrollment that Hedy was talking about. And it's the month that you gain Part B. So again, if it was me turning 65, it'd be June, and then the 5 months after. So it's a total of 6 months, but typically, especially if I'm turning 65, my enrollment paperwork, I could actually submit the 3 months prior. And then, as Hedy mentioned, it's kind of difficult to get into a Medigap plan later on. In most cases, you would have to face medical underwriting if you've gone on to a Medicare Advantage plan and you're 3-4 years down the line, and then you decide, yep, I want to go to a Medigap plan, you are probably going to face medical underwriting. There are some exceptions to that. One is if you're living in, let's say you're living in Portland Metro and you move out to Central Oregon, or you move out to the coast, which I have a lot of clients that are doing. Well, you've left the service area of your Medicare Advantage plan, and the plan that you were on is not offered where you've moved to, because these plans are very specific to the county of your residence. When that happens, you can either A, find another Medicare Advantage plan where you've moved to, and you've got a certain specific amount of time to get this done, or because you involuntarily lost your plan when you moved, you could at that point enroll in a Medicare supplement plan guaranteed issue. So there are some times, once in a blue moon, we don't see it very often, but a Medicare Advantage plan may decide to leave the market. And when that happens, again, you can choose to enroll in another Medicare Advantage plan, or you can go with a Medicare supplement. You have a letter that actually will say that. So we've seen that happen a couple of times. I've been doing this for about 17 years now. The thing with the birthday rule, I always like to clarify this because this gets confusing. So the birthday rule Hedy was talking about, it starts on your birthday and it goes 30 days out here in Oregon. If you were in California, it's actually 60 days, but it's only applicable to people who are already enrolled on a Medigap plan. So if you're on a Medicare Advantage plan, please don't assume that you can use that, what we call birthday rule, to enroll in a Medicare Medigap plan during your birthday months. It won't work. You have to already be on a Medigap plan. And the reason that we use that rule, we actually
Lisa, I'm going to have to stop you here.
Okay.
We got to get on to Hedy's presentation.
Sorry.
Hedy, I want to formally introduce you real quick. You work with Clackamas County SHIBA, which you volunteered to help advise people on their Medicare options. You earned a bachelor's degree in microbiology before going to work for the Veterans Administration as manager of the Microvascular Research Lab. And you ended up working on nationwide VA projects for technical innovations. You retired in 2007, and you've been volunteering for SHIBA for 12 years. So I know you know what you're talking about. Thanks again for joining us, and why don't you take us away with Part D.
Okay, I'll try to make this quick. I know we're running short now. But I'm going to talk about all these subjects here, how you can combine Part D with the other parts of Medicare, what's included, what's not included, how much it costs, when would you like to get a Part D plan, when might you not want to get a Part D plan, how you can get it, when you can change it, how you can find the right plan for you. So let's continue. All right, so combining your Part D plan with other parts of Medicare, the very first one to look at is, okay, I've got Part A or B. Unlike a Medicare Advantage plan or a Medigap, you don't have to have both to get a prescription drug plan. We call those PDPs. So that's one way to do it. Another way is if you have your Part A and B and you picked a Medigap plan, you may recall from what we said earlier that in Medigap plans or A or B, none of that covers drugs. And so if you want drug coverage at this point, you'd have to add on a prescription drug plan. Now, the third way is you had your Part A and B and you decided to go with a Medicare Advantage plan. Well, Part D, for the most part, is included in those plans. So you don't have to get a standalone prescription drug plan. You already have it if you have Part A and B and a Medicare Advantage plan. Okay, next slide. Now, let's talk about what's included. So this again is outpatient medications, prescription drugs. When you're looking for a plan, it's going to be the drugs that are on that plan's formulary. And the formulary is just a list of drugs that the outpatient prescription plans have agreed that they're going to cover that year. So not all the drugs are on there. So make sure when you're looking for a plan that you're not only looking for the cheapest plan, you're looking for a plan with all your drugs on the formulary. And when I say outpatient medications, that's not just the prescription drugs that you go into a pharmacy and get. It's if you're giving yourself injections at home, like for diabetes, insulin injections, for MS, they do that. If you're giving it to yourself at home, that's included as Part D. Okay, next slide. So what's not included? So over-the-counter drugs. So if you go into your pharmacy or grocery store and you pick something that you're using for what you might consider a medical need off the shelf, well, that's not covered. It doesn't have a prescription associated with it. Most vaccines are not included because they are covered by Part B. The drug infusions that are administered in a hospital, infusion clinic, or by a provider, again, are not included. They're all part of Part B coverage, your outpatient coverage. Okay, next slide. So how much does this cost? This gets a little complicated. So the first cost, of course, is the cost of the drug plan, the premium that you're paying for that plan. So that's your base cost. The premiums, as you can see there, run from a little under $8 to $114.50 this year. Most of them are under $40, and we have a whole slew of them that are $0. There's 23 plans available in Oregon right now. So there's plenty to choose from. So the next cost you have to consider is the actual cost of the medications yourself. When you have a prescription drug plan, it's not 100% coverage of your drug costs. So it's going to vary what your drug costs. It's going to vary by the tier designation of the drug with that plan. And what that means is they've divided these drugs into various tiers that they think cost less and more and more and more. So tier 1, for instance, would be a preferred generic brand in that plan. Tier 2 would be maybe a non-preferred generic. And Part 3 would be a brand name drug, and it goes on and on up to specialty drugs. Usually there's a cap at tier 6. And like I say, as you go up that tier designation, the drugs cost a little bit more, and your plan will have a very specific levels here that they work with and reimburse at different amounts. It could be a flat fee, it could be a percentage. They also vary, your medication costs, they vary by the phase of coverage that you're in. So there's that deductible phase when you're paying off your deductible, and in that phase you pay everything up to the deductible amount at the beginning of each year. And then you go into the after deductible or the initial coverage phase, where their tier rates kick in, and that's what they're going to be paying for your drugs. Then if you have a lot of expensive drugs, you may end up in what we call the gap or the donut hole. And during that period, you pay 25% of the retail the retail cost that plan has negotiated with the drug companies to cover. So you'll pay 20%, 25%, or if your plan decides to help you a little bit in the gap, you may pay less than that. And then if you have a really catastrophic year with very expensive drugs and you get to a certain cap, which is generally going to be about a $7,000 out of pocket, then you're in what we call the catastrophic level. And at that point, your costs are much lower. So you have the cost of the drug plan itself, the cost of the medication, and then your choice of pharmacy is also going to impact what it costs. So each plan has preferred or standard or non-preferred pharmacies. And preferred pharmacies usually are less expensive, but not always. So it's worthwhile checking to see which pharmacy you go to and how your plan works with that pharmacy. It also is going to vary by whether you're getting mail order or storefront pharmacy to get your drugs. Often that mail order is cheaper, but not always. So it's worthwhile to look at each plan and see how these different pieces and parts are going to affect your costs. Okay, next slide. I'm sorry, my voice is getting kind of croaky here, but I'll continue. All right, so how much does it cost? We're continuing here. Okay, but we can reduce those costs somewhat if you're lower income. So if you fall within these dollar amounts that I show you here, you could qualify for what we call extra help. That'll help pay for your premium and it'll help lower the cost of your drugs. I have a long link there. Don't really need to worry that so much. You can just type in extra help application online and it'll get you there. Put in Medicare extra help, that'll help. And it'll reduce your costs and expenses. So there's also things that are going to increase your cost and expenses. So for higher incomes, it's just like for your Part B, there's that IRMA, income related monthly adjusted amount. And for the Part D plans, if you make over 91,000 for an individual or 182,000 for a couple, you're going to pay more for your Part D plan percentage-wise than other people do. Back up on reduced cost. Something I forgot to mention is if your income is even close to this amount, but you're a little bit over, go ahead and apply, because there's some things that they don't count. Some are an income they don't count, and other expenses. So it's worthwhile to apply. It doesn't cost anything, and see what they say. Okay, and then we talked about the increased cost. Now, late enrollment fees, just like with Part B, they're going to charge you more, because if you come in late in the game, it's going to cost them more to take care of you than it would have if you come in younger. And so if everybody came in when they were really old and had a lot of expensive drugs, the drug companies would go broke. So for coming in late, they're going to charge you this late enrollment fee. And for Part D plans, it's going to be 1% of the benchmark amount, and I'll explain that in a second. 1% of the benchmark account per month that you did not have Part D, but you could have been from your eligibility date. So that benchmark is something that they determine every year. It's kind of an average of all Part D plans and costs. And they come up with that benchmark amount. So this year it was something like 35. Next year, I think it's something like 40 or 45. I don't have the numbers in hand right now, but that 1% of that amount. Now, at first, that's going to seem like, well, that's not much. I'm paying 35 cents more a month. But when you figure it out, it's going to be that much more every month. And this doesn't stop. It's for the rest of your life. So it does add up. So it's worth considering. Okay, let's move on. Okay, so why might you want to get a Part D plan? Well, you're retiring and you're no longer going to have your employee group plan, and you want some prescription coverage. So you want to add that in. Say you have at least Part A of Medicare and you need prescription coverage. Even if you only have Part A, you can get a prescription coverage. You don't need Part B. If you only have Part B, you can get it, even if you don't have Part A because you didn't want to get it. You were one of those people who pay a high amount for it. Say your insulin or some other drug, some MS drug or cancer drug, is just too expensive without insurance. So you're definitely going to want it. That senior savings model note there just refers to the companies that are participating in some of the lower insulin costs, trying to keep insulin under $35, which is a nice program. Say you want to avoid the Part D late enrollment fees. I mean, that's a good reason to get a Part D plan. Okay, and so the next slide is going to talk about why you might not want to get a Part D plan. So obviously, if you have employee group prescription creditable coverage, and what that means is that they have prescription coverage within their employee group plan that is at least as good as Medicare's coverage. And all the insurers understand what that term means and certify that. So if you have that good creditable coverage, you may not want to get Part D right then. You have a VA prescription coverage. Now, a lot of vets do have good prescription coverage. They really like it. They live near a VA hospital where they can get it. And they don't feel that they need a Part D plan with Medicare. Now, a little caveat here that I'd bring to their attention, though, anybody who's thinking about this, if you had an emergency and you were in an emergency situation, went to an emergency center, the doctors there, when you're all through, give you a prescription for some kind of maintenance. You can't take that prescription to a VA because it's not a VA doctor prescription. So for things like that, it might be worthwhile to get one of those less expensive Part D plans just to be covered in case you're out there away from the VA hospital. Say another reason is I don't take any drugs. Well, again, give it a second thought. A lot of people say, well, I only take aspirin, I don't need drug coverage, but you never know what's going to happen during the year. And there are certain medical conditions that you may come down, unfortunately, with cancer, or you may come down with some disease that's going to require that you get a very expensive medication mid-year. So it's kind of worthwhile to think about getting a less expensive Part D plan just for those kinds of things. And of course, to avoid those late enrollment costs. Okay, next slide. All right, so how can you get it? When can you change it? So getting Part D, when you're just like when you're turning 65, you're eligible on the 25th month of disability. You can start getting those Part D plans. There are not the special enrollment periods for those like there are for Medigap plans. You can change your Part D plan during the special enrollment period. So I should take that back a little bit. But changing your prescription drug plan, you can do it during the open enrollment periods, October 15th to December 7th each year. And then there's special enrollment periods. So things like losing employee coverage, you no longer are going to have that employee Part D coverage that you loved. You're moving out of the area, your plan is discontinued. Or you're sick in the hospital with COVID and you just weren't available to take care of this enrollment period to change your plan or sign up for a plan. That's a qualifying special enrollment period now. And there are so many of them. It's worthwhile checking with SHIBA or with Medicare or a licensed contractor for Medicare plans and look into these special enrollment periods. If you're in a situation that you feel that you couldn't have avoided, it's critical, and you think that you would be justified in requesting a special enrollment period for that circumstance, certainly contact us, see if we can find one for you. Contact Medicare.gov, or I'm sorry, contact Medicare itself. You can, and I have a phone number for that later, and ask them if you don't possibly qualify for some sort of a special enrollment period. It's worth checking. All right, next slide. Okay, so here are Medicare.gov, I mentioned that. There's a plan finder there that's really good at looking for these plans. If you need any help getting around that, SHIBA can help you, Medicare can help you. There's their phone numbers there. And any certified licensed Medicare broker can help you with that as well. Medicare Savings Connect is another good place if you want to look them up online. Okay, did I get through that fast enough?
You did great. We are beyond our 5 o'clock hour. Right. But I want to ask at least one question of you, and Lisa, you're welcome to chime in here too. Is there any way around the donut hole? Can you get on a Medicare Advantage plan and get some help at that stage?
Well, one of the ways of getting around the donut hole is to, and I know a number of people who use this, is that they think that they're going to be close. They can start getting prescriptions with like an Oregon prescription drug plan card, another drug savings card, and keep that off of the Medicare rolls and keep you out of running into the gap.
Yeah, so to Hedy's point, one of the things I use a lot with my clients is referring them to goodrx.com. There's other websites too. Believe it or not, you can use those even if you're on Medicare most cases. A couple of coupons won't let you if you're a Medicare beneficiary. But if you've got things like an inhaler or female hormone replacements, a lot of those tend to be cheaper using the GoodRx coupon. And then it's not going towards that retail dollar amount that's accumulating that would push you into the coverage gap or that donut hole. Other things that you can do for really, really expensive medications, sometimes you can go to the drug manufacturer directly on their website and see if they have any financial assistance programs where the drug manufacturer would pick up your portion, whether it be your deductible or your copays or that 25% during the coverage gap. So that may be an option, especially for really expensive oral chemo drugs. I've seen that numerous times in my career where the client was able to get assistance for that through the drug manufacturer directly.
And one other question, if you have a Part D plan and decide it's not worth the cost and drop it, can you opt back in later?
Yes, but you've got to be cautious because really the only time to enroll in a standalone drug plan or enroll in a Medicare Advantage that has prescription drug coverage, if you've got one that doesn't have it now, is right now, actually during the annual election period. So you'll hear that referred to as the AEP. It's the annual election period. That is really the only time, unless you're having a qualifying event like a special enrollment period because you moved or became Medicaid eligible or lost your Medicaid status. So if you've chosen to go without drug coverage and now you want a plan, you got to focus in on that October 15th through December 7th timeframe. And that coverage won't take effect until January 1st. And do remember, as Hedy pointed out, that there's going to be that 1% late enrollment penalty for each month that you chose to go without drug coverage.
I guess that's the one question I had is if you have drug coverage, let's say from age 65 to 69, then decide to drop it and then decide to go back on at 75, you're going to pay that late enrollment penalty, aren't you, Hedy?
Yeah.
Yes, you are. Yes.
Yeah.
So you can do that, but you will pay a penalty.
And the only time that penalty is wiped away, and Hedy, you may have said this, I was trying to answer some questions, is if you receive Medicaid status, either like through LIS, low income subsidies, through the government, that would wipe away that penalty. But short of that, there's no way to get rid of it.
Yeah. Well, thank you so much, Lisa and Hedy. We've gone past our time. I know there are other questions we didn't get to. We'll try to get to them via email. If you have any further questions, please email me at OregonianMedicare@gmail.com. So Oregonian, all one word, Medicare, all one word, @gmail.com. And I'll do my best to get answers from our panelists or elsewhere that's authoritative for you. I hope you enjoyed our presentation today, and I hope you have a great evening. And thanks again for joining us.